And for our final speaker of the day, I'd like to introduce one of my colleagues, Mumtaz. So Mumtaz is one of the Associate Deans, and Mumtaz has done an awful lot of work about differential attainment. So she's going to talk to us about that this afternoon.
Thank you, Rasheen. So I've got the last slot of the day. I'm really delighted to see loads and loads of people still here, so hopefully I'll try and keep you engaged. And I've got a 40-minute slot, but I'm hoping that if I talk for about 25 minutes or so, and then we have some time for discussion, there is a kind of a natural break point in the middle where I have a discussion sort of bit. But I think given I'm last on the day, I don't want to finish late, I'll probably just leave you with that thought and then bring that discussion at the end, if I may. So as Rasheen said, I'm one of the Postgraduate Associate Deans here. I also, my sort of trademark, I work as a consultant, nephrologist at MRI, and I also work as a quality management lead for the college, Royal College of Physicians. So different heads, and hopefully that kind of brings together this particular topic because I think it needs addressing at different levels. So what I hope to cover is, over the next half an hour or so, is hopefully try and raise a little bit of awareness around some of the research work around differential attainment, understand the challenges of addressing differential attainment, talk about the definitions, and hopefully provide a little framework of how, certainly I've gone about it, others have gone about it, of how we could potentially narrow the gap and hopefully over time improve outcomes. So how did I get into it? So, kind of over the years, I've been sort of my research interest, in addition to other clinical stuff, has been around trainees who run into difficulty. And that kind of arose as an interest when I was a training program director and trying to kind of understand the reasonings behind that, whether we could identify early, how earlier management could then improve outcomes. And when I did that as a bigger study in my deanery role, we looked at the Doctors and Dentists Review Group, which is the TRES, the Trainees Requiring Extra Support Group. That was back in 2016 to 18, and we'd identified a number of trainees who'd been referred in as in difficulty. And when we did it as a kind of breakdown, and more recently we've looked into this further, there was a differential within, kind of gender, ethnicity, and then it was just trying to understand what factors were they, which were kind of related to that. On a national level, more recently I produced this State of Physicianly Training report, which looks at 6 different variables of outcome data, including exam data, ALCP outcome data, PYA reports, various things. But again, when I looked at it from an END perspective, there was variation in outcome. And it was trying to, again, understand and unpick it a little bit. And then that study has become more of a national study that we're doing as part of the Royal College of Physicians, looking at educational environment and looking at the CMT quality criteria. So that's another bigger study to come. I've been part of the EDI group, which is HEE Northwest based, and then nationally I'm an invited member for the GMC advisory group, and we discuss these issues more on a national level with BMA representation, various groups representation, and trying to see what impact we can make, both with understanding it as well as interventions to improve it. So in addition to that, as part of all this work in the Northwest, we've been the pilot site for the GMC for some of the outcome data. And that, again, to understand where the variations are and what interventions we could potentially put into different programs. So various bits of work as a background. So thinking back, what is differential attainment? And there's various definitions where you look. And one of the things, and I think the easiest way to understand it, is different doctors progress through their training at different levels. If it's by sort of their protected characteristics and there's a differentiation, why is that? And I think that's the question I'm trying to understand. So I've been in so many meetings over the years, and I'm sure you have as well, where people tell you that, kind of say international medical graduates don't do so well, BMEs don't do so well, and you think, well, why is that? I don't want to keep hearing data for the sake of data. So that's one of the definitions out there. There's a lot of talk around fairness in medical education, as in the pathway of medical education, both from undergraduate to postgraduates into training, and that's across all professions. So in my various undergraduate roles as well, I'm learning that there's lots of work around this in various professional, kind of settings. Universities are looking into it as well. And again, it's trying to understand why those differences are and taking into account different characteristics. Why is there a difference and what can we do about it? So when you think about the scale of the problem, I think this slide is always quite striking. I'm sure some of you have seen it already and heard me talking about it. But I think the differences exist at all levels. When you look at postgraduate exams, I think that's where the widest gaps are. And then it always strikes me as well as in the differences. So if you put in all the total postgraduate exam results, this is GMC data, UK white graduates, 75% pass rate. When you look at the British minority ethnic groups like myself, 63%, and then the international medical graduates all the way down to 41%. We know that. It's there for years and years. So, and it's decades. Obviously, there's been judiciary reviews around this, particularly for the Royal College of GP exams over the years. There's similar challenges for various other colleges as well. But beyond that, I mean, yes, we can't rule out discrimination and bias. That's there at the bottom. But I think, on a wider scale, I think it's trying to understand why the variation exists and what we, as educators at different levels, can do to try and address the issue. So, understanding differential attainment. So this is, I think, a slide which I find really helpful to try and understand at different levels what individuals and people can do. So on a macro level, kind of the wider policies, exam structures, the board. In my college role, I sit on various exam boards. I sit on the assessment panels and things. And when people are designing assessments, I think at a higher national profile level, I think that's important to consider. And I think, sort of those boards, that needs to be kind of on the agenda, which it is. Then from deanery kind of level or, kind of regional level, I think we have an input towards how recruitment works, how induction works, how support for our trainees work, assessment locally, how that's conducted. So I think at meso level, that's important. And perhaps, kind of we have some influence in those arenas. And then when you look at the individual sort of micro level, I think every interaction we have with trainees, I think we can influence and, interact. I talk a lot about holistic educational supervision. I guess with my background, it's easier to have some conversations which may be difficult, but I think trying to understand learning styles, culture, language interactions, other barriers, and trying to then put it as a positive spin, as more enablers, is, I think, where we as individuals could possibly make a difference. So, why is it important? So, I think that from the GMC side, the bit of work that I do with them, obviously there's a legal obligation around all of this to investigate these issues. There is a responsibility from HEE, the trust, education providers to be thinking about that, and it's promoting fairness and equity for all. We're not just saying about ethnicity or gender. I think it's across the board. I think this is kind of goes beyond that. And as we all know, if individuals don't attain their potential, then we all lose out, and potentially it can have an impact on patient safety, and there's increasing evidence around this as well. And we need to ensure that if there are barriers, what are they? And, how can we make those barriers less so and make more enablers? So getting that balance right with getting the support towards the trainees. And if there is any evidence of bias, discrimination, or, kind of anything which is not clear, then that needs to be looked at and addressed in more detail. And over time, the aim would be that rather than hearing about these statistics all the time, that there is a difference, something changes, something improves, and that, I guess, is the ultimate gain. So from the GMC perspective, I guess I've been involved for about, 3 or 4 years with this kind of work, and it's been kind of like a 3-year plan, a 5-year plan, and up to 2020, these were the kind of objectives to achieve. So it's trying to build capacity within organisations to think about it, to develop kind of some kind of resource of trying to understand as well as evaluate, and then put measures into place which are useful interventions which can then be evaluated. It's facilitating and sharing good practice. It's about collecting data and looking at it, analysing it, and again, understanding it rather than just presenting the data. And it's working with the wider healthcare workforce because it is across all boards. So the most powerful presentation I heard at the GMC recently was done by an Afro-Caribbean lady who's a kind of a chief nurse in one of the London hospitals, and her challenges over the years and kind of how she overcame them and things. And some of the statistics are quite striking, which, kind of when presented in that way is quite unexpected. So the different work streams which are being developed and I'm part of, so the developing matrix or a way of kind of collating the data, which could be useful. Again, research into best practice around design of assessments, evaluation, awareness of the barriers and potential kind of enablers and trying to kind of promote those. And again, the bottom bit, understanding the root causes of why this is the case. And then if we understand it, then we can do something more useful around it. So metrics for differential attainment, having said data is there, but I think trying to target then the interventions to where, problems may be, kind of more prevalent is useful. And in addition to that, I think it's useful to understand where there's narrower gap. Why is it better in certain specialties and programs as well? So how can we do that? So the metrics that have been developed by the GMC, which I get access to, and then I work with schools and programs around that, looks at ARCP outcomes, exam outcomes, and then the GMC overall satisfaction score, which is used as a marker of educational sort of overall satisfaction. So the environment of how that is. It's a composite score, and it's presented a little bit like the GMC survey. I'm sure people have positive, negative thoughts around that. But this is the kind of data that you see. This is just more of an example of how the data is presented. So you have your specialties, you have your programs, you have your regions, you have 9 potential matrix per individual and per program. And then it's your white UK trained person who is the baseline, and then the comparatives for your ARCP, MRC exam outcomes, and your overall satisfaction score is then measured against international medical graduates, the European sort of trainees, and then the British minority ethnic groups as well. And then that's the kind of data which gets presented on GMC Connect, which then I look at and then work with programs and things. This is too small to replicate. What I do with individual programs and schools is then take their school and their level data to then speak with heads of schools and various training program directors to then try and understand and tease it out. So when you look at combined specialties, I'll just talk it through, it's too little to explain or look at properly. There are significant differences between ARCP outcomes, exam outcomes, as you would expect, particularly so with the international medical graduates, less so in the BME and less so in some EEA graduates. But this varies. So you look at all specialties, then you can look at training program level, you can look at individual school programs, and then there's variation, and it's then trying to understand that better. So that's what I've been doing for the last in addition to everything else over the last year or so. And this is just what I want you to do is just take some of these questions in. We'll come back to that rather than breaking it up for discussion now, then we won't be able to finish it in time. So what I would individually like you to kind of think about, as I'm talking, is what kind of issues do you feel personally within your areas, within your programs, may contribute towards differential attainment? And, to narrow this gap, how can you individually possibly make a difference? At a trust level, how could you approach it? At the deanery or school or program level, how can we approach it? And then if you do have college roles, kind of policy level, is there some influence that we as individuals can play in the bigger picture as well? So that's just kind of leaving you with a thought. When I do this as a workshop, then I leave you to have a think, feedback, but we can have some of this discussion as I go along towards the end, if that's okay, because I'm conscious of time and I don't want to keep you. So there's a number of sort of research groups who've been looking at perceived causes of differential attainment. Catherine Wolfe, who I work with through the GMC, UCL based, who's a psychologist who has done a lot of work around both perceived causes, barriers, enablers, and then interventions. And that's been her work stream over the last kind of 5 to 7 years. And it's, kind of, she broke it down to different factors, kind of relationships within kind of the working environment, both with seniors or within peers, then, kind of the environment bit within the kind of the actual setting where they are and barriers around that, then the curricula, the learning, the assessment. So, again, not rocket science. And if you read through some of those, kind of comments, and this is generated from data from focus groups as well as individual questionnaire-based, very much qualitative-based studies of both trainees and trainers of various groups, and then kind of collated thematic analysis, which kind of has come up with this nice diagram. But there's some references at the bottom, and you can read some of the narrative around that if you're interested. And then that led to kind of the Fair Training Pathways work, which is part of Kath Wolfe's work. And that kind of breaks it down to risks and vulnerability process. So the bits that are possible causes and the things that what trainees individually came up with, things that they thought might help in the ideal world if that was possible. So, poor relationship with seniors, perception of unconscious bias, poorer performance. I mean, I have a number of trainees that I've looked after and mentored over the years, and it all sounds pretty familiar. I don't think it was rocket science when, some of the things, when you sort of saw it, you think, gosh, I have seen that. Perhaps I've seen that too, but what could I do with it? And what do trainees themselves feel might make a difference? And we ourselves, which I'll present in a bit, did some focus group work with some of our trainees as well, and get them to do action planning and get them to come up with some ideas as well. And I'll go on to that in a minute. So, I think more around support, some bits around structure, and some, kind of bits around kind of overall assessment processes and how those can be improved as well. And this was a slide which I asked and kind of got from one of our work psychology groups. That's the East Midlands group that have done a lot of work around earlier identification and intervention of trainees requiring extra support. And certainly I got involved with them when I was doing my sort of Doctors in Difficulty stuff some years ago. And again, they looked at it as a continuum from, undergraduate to postgraduate years. They focused on some of the GMC data and looked at, things which were positive. So even when I've looked at the data, I've looked at where the gap is very wide, but also where the gap is really narrow or it doesn't exist. So why doesn't it exist in some schools and programs or less so? So when they've looked at it that way, the things that came up more so, again, kind of inspirational sort of seniors support, kind of a lot around mentoring and support as well. So the learning pathway, how it goes at the top, and then who supports learning, how that can be improved, what supports learning, what can we do? So it's nice kind of pointers. And again, this has come from groups of both trainers, trainees, where the gaps are less so, to kind of say what has actually worked for them and how best can we support trainees to succeed. And then when we've looked at it separately, I like the GMC themes and standards. I've done that with various bits of work that I've done. And I think it breaks it down quite nicely when you think about education environment, governance, and it's how we conduct our, kind of visits and things as well. So it's how my brain is structured. But when you think about it, what needs to be done to make our educational environment more inclusive? How can we improve on educational supervision? So, very basic questions. What support can we provide to trainees, to trainers? And how can we look at the curricula? And then when you look at that in more detail, then you can probably logically think through of some of the bits where you can perhaps make an influence or change. So, there's local trusts that, I work at and support, have very much of an enhanced induction programme, top-loading support, rather than waiting for trainees to then get into difficulty or have problems, providing support very early on, placements, recruitment, loads of different areas where potential focus could be. So that's just giving some kind of ideas. Of course, all the slides and things will be shared afterwards, so I know there's a lot of detail on some of the ones, but please do take them away and have a read after. So when we've talked about interventions, so over the course of the last sort of year or two, particularly for us in HE Northwest, what I've been doing is a number of focus groups. I've done various presentations and workshops with different schools and programs. And we get, if we're doing it trainee focused, we do a bit on their past, as in their experiences, the present, what it is like now, and then get them to do some action planning of how they would, want it in the ideal world, some blue sky thinking. And a lot of the bits that have come out is from, kind of collated data from a lot of the workshops that we've been running, both with trainees and with trainers as well. And the kind of things that they come up with, so this is broken up over 2 slides matched to the GMC themes. So, again, promoting, there's a lot of talk around cultural competence, cultural sensitivity, unconscious bias. I think the understanding around that can be a little bit, sort of unclear when we've ran the workshops themselves. Claire, who does more of the EDI work, we've run a few workshops in those lines with different schools and programs. Developing educators more to have, promote diversity and inclusiveness. The holistic educational supervision, how in practice we can make that function. I'll give some tips and some other bits which are more specific over the next few slides. And then some of the bits which have asterisks have come specifically from trainees. So developing a culture of support, kind of around feedback. There's a lot around incidents and reducing the blame culture. There's a lot around support for individual trainees returning back, kind of from gaps from training and things, which comes up later as well. From an educational governance perspective, there's various things that individuals, trusts and kind of deanery level and programme level could be done. And that's, again, kind of highlighted there. So a few things to take away. So again, systems in place to identify, kind of issues earlier, preventing a blame-free culture, that always comes up from the trainees. Patients as educators within, kind of a greater involvement of individual trainees and having more of a diverse group in the different groups and meetings that individuals are running. And then supporting learners. Some mentoring always comes up. So every time we've done a workshop, they'll talk about peer matched mentoring, kind of schemes. And I know some programs run them quite well. So particularly for the core training program workshops that we've done for psychiatry, for surgery, for medicine, that comes up repeatedly. So the core training too could support the, sort of the first year trainee and how that could work and be integrated within their learning as well. The supporting educators, I think, we're all short of time, and I think it's trying to kind of build in things that could support us to support our trainees, which again, kind of a lot of the things, I know some things are already being done in different areas as well. And around curricular and assessment, a lot is around just, kind of fairer assessment, but again, some specific examples shared over there as well. So the bits that I'm currently doing, like I say, sort of we had the regional data which was shared last year, and based on that analysis, what I'd done was targeted programs which are both positive outliers. I like to have a balanced approach rather than just, kind of focusing on the negatives and trying to see if the gaps are narrow in certain programs, why is that? To understand that better, what are certain programs doing which, kind of others could possibly learn from as well. So there's been some work around that, and then we've developed various action plans across the way, and some of the work has been presented at various meetings. So one of the things as an approach, kind of from our regional deanery level, which, kind of we think is quite helpful for each programme to kind of break it down and look at. So when you present this, everybody always says, God, it's too big a problem. Where do we focus? What do we do? And I know the GP school have been looking at this for, kind of many years ahead of certainly sort of the School of Medicine perhaps and other schools, but having a stepwise approach around it. So if you start off with the training pathway or training journey, where recruitment comes in, selection, placements. So for example, when we were doing the trainees in difficulty stuff, particularly for foundation, the people with the lower scores went to the furthest away place. The lack of support then probably aggravated the problem, and it just compounds things. So particularly in the GP school, a lot of the placements are based on educational needs. I know it's not always possible, but it's very much tailored, and there's kind of more enhanced supervision for trainees who may potentially require extra support. And a lot of the support is top-loaded early. So, kind of having that at an earlier stage of a shadowing period, or a, you know, kind of a getting to know your environment better before you're actually working in it, certainly does help. And kind of having an enhanced program of induction based on individual training needs, and perhaps grouping things out if need be. And then at the same time of doing a lot of the support stuff, our faculty need to be trained as well in the different kind of areas that I've kind of highlighted there. And then there's a lot of work, and a lot of my work, earlier work, focused on the early assessment of risk. So, you know, kind of portfolio evaluations, exam outcomes, and, you know, ARCP outcomes in particular are at the end of the year. What you want to be doing is, you know, kind of identifying who would require support early. And there are some mechanisms, certainly sort of some of the work that I've published, you know, kind of you can have potential modelling that you can do based on, you know, recruitment scores, interview scores, first MSF, supervisor reports, to try and then identify and then put in support early, so that at the end of the year then outcomes could potentially be improved, rather than waiting for those outcomes to be adverse to then add in extra support. So some just simple things, you know, kind of, again, this is more so from Kath Wolf's work, but again, stuff that we've found locally as well. So, you know, simple things, recognising diversity and treating not everyone as a homogeneous group. I mean, again, some of these things comes out from the individual trainee groups as well. The monitoring of the data, I think, you know, not completely homing in and making that an absolute, but I think it's important to just, you know, kind of do evaluate and use it as a positive tool, as in, you know, providing extra support earlier, rather than targeting as in, well, you're going to fail, so we don't give you extra support, is again how you frame these things as well. And that's around, again, the identification. If you mention that more around giving support, then I think I've found that works better. And then mentoring and role models comes time and time again. I think, you know, kind of positive role models have really supported so many training journeys. And I think, you know, as individuals, we could potentially influence that as well. And I talk a lot around the holistic approach, you know, kind of thinking more widely, particularly for the international medical graduates, around, you know, sort of housing, visas, practical stuff. And there's, you know, you can signpost things. Even if you don't know, you can ask and then help, rather than just people thrown in the deep end sometimes without that additional support. And for trainees or students, you think that, well, they need to be empowered enough to ask, you know, and I think, again, as our role as an educator, if we empower them so that they can ask for support and feel comfortable to do that, then that in itself is helping, isn't it? So the trainees themselves can seek out other trainees sort of for support, asking for help, mentors, giving feedback back to the trainees. But if they're not confident, and if they're not, you know, kind of empowered enough to do that, then they just run into problems without receiving any additional support. So the bits that we're doing, like I say, sort of, we've done a number of trainee and trainer-led workshops. We're trying to collate the data, sharing best practice, good practice, trying to put in some interventions in. On a kind of sort of separate level, we're working with Edge Hill, which is our partner kind of university from sort of HEE, and we're designing kind of more of a, I mean, you get your EDI training as part of mandatory training, but we were just discussing how effective that could or couldn't be. But it's trying to kind of embed, you know, kind of good practice and learn from scenarios, perhaps, to kind of see how important and how individuals can make change. And then on a more research base, which I guess I come from that kind of background, what I'm trying to understand is what is out there. Because some of the sort of discussions around perceived causes, even interventions, are all, you know, kind of targeted in small group studies. Yes, qualitative and quantitative studies are important, but where are the research gaps? How can we make a difference? How can we look at that? So we've just recently completed a scoping review, and hopefully that will be published soon. And then we're trying to develop interventions to then kind of further the work based on evidence. And I produce kind of quarterly action plans for the GMC, which then kind of furthers their work, and we can learn from what other deaneries, colleges are doing as well. So sorry, I've talked a bit. I possibly have rushed a little, but I wanted to not make my presentation too late. So I hope I've achieved some of the outcomes that I'd set at the beginning, which was covering some of the research work, trying to understand the bigger challenge, and hopefully trying to home in some of the kind of interventions or trying to think about it on how potential interventions could work in a kind of a structured way. So thank you for listening, and any questions? Thank you. Sorry, I don't have a thing.
There isn't a microphone, but I was told earlier I don't need a microphone, so I'll see how that goes. Well, thank you. Well, I really wanted to say thank you very much, Mumtaz, for an excellent presentation, very thought-provoking, and although you said that some people would have heard you before, many would not have done, and you've given us a huge amount of stuff to think about. I'm sure that there are going to be some questions. Would people like to raise their hands and a microphone will come to you, and then you can say who you are and what your question is?
I'm Suzanne Gorn, I'm DME from East Lancs. I know that a lot of this is, we did our SAR for the first time last year, and there's a section around D&D and things, and we had some feedback recently. And I was just wondering if there was any possibility, because some of our feedback was around collecting the data for our doctors in training, around the ARCP outcomes. And I was wondering if there was any possibility of getting the data for core trainees and STs, which we don't easily have access to. Obviously, we have the foundation data. The breakdown that you did for schools, is there any way of getting that breakdown for trusts?
So that's what we're working upon with the GMC. So initially, the data that got sort of shared and what's on the GMC Connect site, which I have access to, is at programme and region level rather than trust level. What we're trying to sort of say, and they have got it, is just trying to tease it out from the GMC, is to say what would be most useful to make the change and, you know, implement things would be useful to have it on a trust level. So we don't have that just yet, as in the rollout data that I presented, but that should be coming fairly soon, hopefully over months. And the EDI tool that Claire, we developed a little framework, or certainly Claire did, of putting the questions within the SAR report to give targeted feedback. And again, just promote the discussion, and we're doing similar things for when we're doing the visits, as well as the other reports that we're collating as well. So again, if people haven't, I'm sure people are thinking about it and have done lots of things about it, but sometimes it seems that the trust has EDI leads which are doing things multi-professionally, and it doesn't always come down to sort of postgraduate medical education. Thank you.
Thinking about the mentoring scheme, for example, as a TPD, and I've got some new trainees, we do actually offer through just an informal buddying scheme.
Yes.
And would it be seen as inappropriate to say that I would be matching people? So if I had a female trainee from Northern Ireland, to find them a mentor female consultant from Northern Ireland as their mentor, would that be appropriate or inappropriate?
Yeah, I mean, when you ask the trainees that same question, which is what we did when we did the focus group, so they always kind of come up with, when we get them to do the action planning, mentoring always comes up. And then we delve into that same question to say, if it's an international medical graduate, would you want another international medical graduate? And you get varying responses. So I think, you know, again, asking, but if you have the pool, so some smaller programs and specialties would struggle just with the number of people that they would have, and then that choice might not be so open. But certainly with big programs, right, core medicine, surgery, you know, kind of psychiatry, you could potentially have a choice. And again, it's the training around that. So what they were saying is that, you know, we're offered a buddy or we're offered a mentor-mentee, but it's the training around that as well. So some are really, really good, and some are naturally empathic and would be supportive and things, and others are possibly just, you know, attached and not really interested or whatever. So it's A, getting the engaged crowd, and B, you know, kind of getting them trained up in a way, you know, kind of which is then going to be effective. But I'd just say ask the individual trainees really if they had a preference, if you had that, or give them a you know, kind of some flexibility that they could be changed. You know, they could be matched up with somebody, but if it's not working out, because I think what a lot of trainees were saying is that they were paired up or matched up with someone, it worked beautifully well for the year, but with others it really didn't work. They never saw anyone, but they didn't tell anybody to then, you know, assign. So again, it's making that quite clear at the outset that it's fine, you know, if it's not working, let us know and we can change that. Thank you.
Mumtaz, can I ask a question? Because you presented a huge amount of evidence, some of it from trainees, much of it from other groups.
Yeah.
How aware are the trainees of what they can do? Your tips at the end, perhaps, and how empowered do they actually feel about taking things into their own hands?
Yeah. So, I mean, from the workshops that we've done locally, and even when I do them externally as well, what we get them to do is this action planning bit. And then what we ask is that the educators and the training program directors then support them to take things forwards. So even some of the trainees from the workshops that we've run recently have come up with ideas, and then me and Claire are supporting them to even do like little mini QI projects, trying to take it back to their programs or their trusts. And they're really good. I mean, you know, the trainees do, if they're engaged, you know, and if they're interested, they themselves can take things forward. So even like one of the surgical trainees was saying about a global health, you know, kind of module in surgical training pathways. And we've linked her up with various people, and she's got, you know, okay, it might not come to complete fruition, but at least there's some discussion around it. And there's some high level discussions around those things as well. And even around specific kind of mentoring schemes, you know, the buddying side of things, as well as trying to get, you know, access of a more diverse group in various governance groups and things as well, of how, you know, kind of that could be facilitated both through the TPDs, the DMEs, you know, both the trust kind of education pathway as well as the deanery education pathway.
Thank you very much. I don't think I see any other hands up. Can I thank you very much for keeping the audience here for so long? I think this reflects their interest and commitment